So I want to talk about electrical versus mechanical activity of the heart. Mechanical activity of the heart is what people generally associate with what the heart does, which is like when the chambers contract and relax, or the valves open and close. That's all mechanical activity. The mechanical activity of the heart is ultimately controlled by the electrical activity of the heart. And the electrical activity is when the SA node sends an electrical signal, and then the AV node gets it, and then it signals through the ventricles, right? Okay, so that is often called the conduction system of the heart, right? The electrical conduction system of the heart. So let's talk about some abnormalities of conduction. Abnormalities of conduction will cause mechanical abnormalities, okay? There are a bunch of them. I'm definitely not going to talk about all of them, but I want to talk about two of them. So what should happen in a healthy heart is the SA node should send an electrical signal, and then the atrial will contract because of that. And then the AV node was already on its way to an electrical signal, but the SA node takes it over and says, do it now, coordinated with what I said. And then the AV node sends it down, the bundle and the left and right bundle branches up the Purkinje fibers, and then you get ventricular contraction. Okay, so what can happen is you can get some abnormalities of conduction. This one is called fibrillation. There's two different kinds of fibrillation. One of them is a way bigger deal than the other one. Atrial fibrillation is when your ventricles are still doing what they're supposed to do, and they will continue contracting because the AV node does its own thing, even if the SA node doesn't tell it what to do, right? So the ventricles will continue contracting, but your atria are spazzing out, right? So your atria are doing this and your ventricles are still doing this. Is that necessarily going to kill you? No, because remember that 80% of the blood gets from the atria to the ventricles, even in the absence of atrial contraction. What it will do is it will drop your blood flow by about 20%, okay? Which is pretty dramatic. I have atrial fibrillation. When that occurs, depending on how active I am, I can either pass out or just get kind of woozy, right? So that's atrial fibrillation. And so these guys are spazzing out. And it's primarily because there's just an electrical storm in the atria. Mine is related to the damage that I had when I was a kid. So what's the big risk with atrial fibrillation? Atrial fibrillation, the big risk is not immediate, unless of course I'm driving my car and then I can like pass out and kill everybody. The big risk is that blood that's sitting there, that 20%, is supposed to be moving. What's the problem if blood just sits around? Clotting, exactly. So the big deal with atrial fibrillation is that if you're in a decently long bout of atrial fibrillation, say hours, not minutes, right? You are at an increased risk of throwing a clot for up to 2 weeks afterward. And throwing a clot to the heart will cause a heart attack, and throwing it to the brain will cause a stroke, right? So that's the big risk with atrial fibrillation. Now, if atrial fibrillation is bad enough, they can give you things that are anticoagulants, right? They'll give you an anticoagulant, or they can give you something that helps regulate your heart rate, like digitalis or digoxin. If it's not, doesn't happen very often, then they don't worry about it. When you are in atrial fibrillation for a really long time, sometimes they will actually cardiovert you. They will actually clear out the electrical signal. But I was in atrial fibrillation for 18 hours one time, and they didn't cardiovert me. And the reason is because I'm going to live, right, through this. And when they stop your heart with cardioversion, they wait for it to start again, and it can kill you. That alone can kill you. So they don't usually shock you with atrial fibrillation, although they can. But with ventricular fibrillation, it's a way bigger deal. So with ventricular fibrillation, what's happening is your atria are doing their thing, so the SA node is behaving. But the whole other part of the electrical circuit, the AV node, is spazzing out. So your ventricles are doing this, even though your atria are doing this, right? Your ventricles are spazzing out. Now, that will kill you. It sometimes takes minutes, sometimes takes hours to kill you, depending on how bad it is. And with that one, what's going to happen is, since the ventricles are pumping chambers, right? Your blood is not being pumped adequately, which can cause a stroke. But the other thing is, what happens when you're continually compressing the ventricles? What happens to the blood flow to the heart muscle itself? Yeah, you're compressing the capillaries of the heart, so you can cause a heart attack with this one. So with ventricular fibrillation, far more frequently, they will actually shock you and defibrillate. And when they defibrillate, a lot of people think they're trying to start your heart, but they're not. What they're trying to do is trying to stop it from misbehaving electrically. They are clearing out all of the electrical activity of the heart. And you guys have seen Grey's Anatomy. What do they do after that? They wait, right? You wait and you stare at the monitor to see if it starts again, because you're waiting for the SA node to reinitiate the heart rate. Now, why the hell will you do that? Well, you were about to die anyway. That's why they're going to do it, right? So they're going to stop the heart with defibrillation. They'll do that with ventricular tachycardia as well when your ventricles are going too. But they won't do it with all electrical abnormalities. It has to be pretty damn serious, right? Because you're about to start to stop the heart. So fibrillating ventricles are useless as pumps, and fibrillating atria you can live with for quite a while. Okay, so that's the last of heart, and we'll start on vessels. So first we're going to do just the basics of how vessels are formed and all that kind of stuff, and then we'll get into specific vessels that you guys are going to do in lab. So first thing, let's get an appreciation for how many vessels you actually have. It is freaking crazy. So did any of you guys go to Body Worlds when it was here? Did you see it? Okay, you should totally go the next time. It'll come to Leonardo again. It is fascinating. It's beautifully done. And one of the preparations that they do, did you see the animal one? Did anybody go to the animal one but me? Oh my God, the animal one was amazing. If you have never seen a giraffe, and you never have, a giraffe's nervous system, so flippin' cool. Oh my gosh, there's so many nerves, there's so much neck. That was so awesome, I loved it. One of the preparations that they have, both in the animal and in the human one, is they have this preparation in which they impregnate all of the blood vessels of the body with a plastic. It's plastic. It's a different kind of plastination than the muscle plastination. And so what they do is they inject it, and it's liquid enough that it even gets into some of the smaller capillaries, not all of them. And then what they do is they take that cadaver, or that part, that body part, and they submerge it in something that disintegrates all of the tissues that are not plastinated. And then what you get is you get a complete outline of the blood vessels, and you can see that like your blood vessels come within millimeters of every single cell in your body. It's pretty damn amazing. So that's the one with the heart, with the brain. Here's one with the heart. You can see how much blood flow you have to the heart. This one didn't even get all of the capillaries. So you have, in about a 150-pound person, you have 60,000 miles of blood vessels. The vast majority of them are capillaries. So capillaries are highly, highly branched, and you've got tons of them. Seriously, go to this if you have kids. They're going to think it's the coolest damn thing ever. So this was one of the few times that my son thought I was brilliant, because I know the names of everything. He even stopped asking Dad in the middle of it. What is that? I'm like, your dad's a feminist. He's offended by this too. Okay, so you have 60,000 miles of blood vessels. So I wanted to just go through the basic structure of blood vessels in general and then compare arteries and veins. So first thing is, this is counterintuitive, but this is a cross-section between an artery and a vein. One of the things that you will see is that this, I don't know which one it is because it didn't tell me, but let's just say this is the brachial artery and the brachial vein, or the femoral and the femoral, right? Because they're right next to each other, okay? What we will see is that in an artery, it's going to have a much thicker wall. This will help to maintain the pressure. It will also help to deal with the pressure. That thicker wall will keep it from ballooning out. But it means that it has a smaller lumen. Does that make sense? And a vein of the same size will have a bigger lumen and it will be more collapsible. So arteries and veins are different in their histology and the structure of their wall. So let's look at how they're different. So the way that they're different is vessels generally have three what we call tunics, like coats. They have an external one called the tunica externa, tunica media, which is in the middle, and then a tunica intima or interna, which is the one that's in contact with the blood. Okay, so let's look at them. If you start from the inside, you will see the difference in the lumen size of an artery and a vein. The inner layer of all blood vessels should be the slipperiest simple squamous epithelium that you can get. It's called endothelium. Okay, and then underneath that, you are going to have some connective tissue in both of them. This connective tissue has some collagen fibers and some elastic fibers. It's primarily loose areolar connective tissue, so it's going to be. But then notice that we'll run into the first big difference. And the first big difference is that if you're an artery, you're going to have an extra layer of elastic, and if you're a vein, you won't. So why is elasticity way more important in arteries than it is in veins? Higher pressure, and also variable pressure, right? So arteries not only receive higher pressure generally, but they also receive squirts of blood, right? So you need to be able to balloon out, snap back, balloon out, snap back, right? So you've got an extra layer of elastic here. And then notice the next thing, we're in the tunica media now, the middle layer, which is mostly muscle. The tunica media has a much thicker layer of smooth muscle in an artery than a vein. And the smooth muscle is not always about wiggling. What can the smooth muscle be about? For instance, if this is the aorta, we don't ever want it to vasoconstrict, do we? So what is the musculature in the wall of the aorta? And it's got a lot of musculature. What is it for? Any idea? Yes, it is actually structural stability of the size of the lumen, right? So it's always there, and it's always like slightly tensed, right? Not so much that you change the size, but just so much that it's like Red Rover ready for the blood coming out, right? So it's about either structural stability, and some arteries are wiggly, but not the ones that are closest to the heart, because that's a bad plan, right? And then this one is way thinner, okay? Nowhere near as much pressure, not as much problem with structural stability. They're also not going to be as wiggly, generally speaking. And then you're going to have another layer of elastic in an artery, so it's got 2 extra layers of elastic. This one doesn't have it. And then you've got this outer layer, and this outer layer is connective tissue. The connective tissue, the tunica externa. Arteries and veins are actually have connective tissue on the outside. They're actually woven into the tissue around them. So for instance, when you start looking at vessels next week, you couldn't skin an arm and see the blood vessels generally. I mean, with the exception of the ones that are super superficial, because they are woven into the tissue. The reason you can see them is because we put a probe under it and slide it to pull it away from the connective tissue so that you can see that it's actually different than the muscle. So the arteries and veins are all woven into the tissue around them. So, and then on the outside, by the way, they have blood vessels that capillaries to themselves. Because this part right here is, of course, going to get oxygen from the blood that's in it, especially on this one. But this doesn't. So they actually have a capillary bed that goes to the outside of the blood vessel, which is called the vasa vasorum. I never ask about that, but that's why it's got blood vessels in it. Okay, so how is a capillary different than an artery and a vein? The biggest difference is that all of these extra tunics, the media and the externa, it doesn't have. Really, all it has is the endothelium plus a basement membrane. And that's good because it's incredibly thin, and that's great for gas exchange, especially if you add in the fact that it's like incredibly branched. Super, super good for gas and nutrient exchange. So, but it also means that this guy cannot protect himself, right? If blood pressure is really high and high blood pressure gets straight to a capillary, you just bust them. Have you ever seen like a crime drama in which you can tell that somebody was strangled because the blood vessels in their face and their eyeballs were popped? So all the blood, like in the capillaries, gets too high. Has anybody ever thrown up so much that they busted their blood vessels in their face? No? That was my first trimester of pregnancy. It was like, bleh. It's like, bleh. Okay. All right, so the tunica media, the middle layer right here. So if you look at the arrangement of the smooth muscle cells, so if this is the tube, the smooth muscle cells are arranged circularly. So what I want to know is if those smooth muscle cells contract, what does it do to the diameter of the tube? Shrinks it or constricts it. Does that make sense? Okay. And that constriction will be primarily controlled by the autonomic nervous system, specifically the sympathetic nervous system. Okay, so let's get to arteries specifically now. So if we're looking at arteries specifically, arteries are defined as carrying blood away from the heart. That's why they're often referred to as efferent vessels. Good? And you guys know this. They carry oxygenated blood in what circuit? Systemic, and deoxygenated blood in the pulmonary circuit. Good. Okay. The vessel wall has to be thicker and stronger and also more elastic than a vein because the pressure is higher and more variable. So as a result of the structure of the wall that we talked about, the primary characteristics of arteries are elasticity and also contractility. Not contractility meaning they always get smaller, but that they have the ability to have tensile strength and also wiggly. Okay, so like I mentioned, the smooth muscle in the walls of all of your vessels, not just your arteries, is primarily controlled by the sympathetic nervous system, although there are hormones that can do it too. There are hormones that can cause vasoconstriction, vasodilation, but primarily it's the sympathetic nervous system that will do that. Okay, so most parts of the body actually evolutionarily, let's talk about this. It's not always a good plan to have a single source of arterial blood. So if you've got this capillary bed, and it's a really important capillary bed, and it's a systemic capillary bed, okay, and I have one artery going to it, right, and then something happens. Oops, it was nice having a brain. So you can see why evolutionarily quite often what developed, especially for non-regenerative capillary beds, is this redundancy in circulation called collateral circulation. Does that make sense? Okay. And collateral circulation, and in addition to redundancy, there's also an alternate route. So if I got blocked here, I don't drop blood flow by half. I actually just recircuit the blood flow, right? Does that make sense? So this concept is called collateral circulation. This alternate route is called an anastomosis. Okay, anastomoses develop quite often with arterial flow to capillary beds. They also develop with venous drainage back. So let me show you a classic anastomosis that is the reason that most of us are alive, especially me. Okay, so this is blood flow to the brain, and you're going to learn these vessels a little bit later. We'll probably start on them today, but not finish them. The blood flow to the brain primarily comes through 4 arteries. These 2 internal carotid arteries that go through the carotid canals, yes? And then these 2 vertebral arteries that go up the transverse foramina of the cervical vertebra and then fold anterior to it. Okay, so what would happen if, for instance, I had a blockage right here? Do I just lose this hemisphere of my cerebrum? No, what I do is I send the same amount of blood around this way, right? So this circle that you have in the middle there is a phenomenal example of collateral circulation. It's called the circle of Willis, or a cerebral arterial circle. And this whole collateral circulation to the brain thing is the reason that I'm still alive. I had this abnormality in my cardiovascular system that I got super stressed out a couple years ago. My husband and I almost got divorced. Everything was going to shit. And what happened was, in combination with this like anatomical abnormality in my blood vessels, I actually popped a fistula between my right vertebral artery straight into my right vertebral vein. And so the blood was not going up anymore. It was not going through the capillary bed. These 2 collectively deliver 25% of the blood supplied to my brain. So in theory, I should have lost around 12, 13% of my blood supply to my brain, right? But I didn't have a stroke. Matter of fact, I knew when it happened because I could, like, all of a sudden, I could hear the blood flow through my head. It was like radiating through my skull because it was like really turbulent. And I could shoo, shoo, shoo. And I heard it for like a year and a half. I don't know why I didn't go to the doctor. I've already got a heart problem. You would think I would be smart. But I was dealing with a lot of stuff, a lot. Okay? So after stuff stopped, and I figured out I was going to survive no matter what. I'm like, I am literally going to be fine. Okay? I had to convince. Then I went to my cardiologist. And so as my cardiologist was checking my heart, I was like, while you're doing that, could you just like take the stethoscope and listen up here? It's not a good idea. It's not a good sign when your cardiologist says, oh shit. And he sent me directly to you, to interventional radiology. And what they figured out is the blood that was going directly from this vessel, bypassing the capillary bed and straight into the vein. But since it was a year and a half later, I was like, well, so doctor, do I actually really need to get this fixed? Because, like, is it just the sound? Because now I just sleep with really loud white noise and I have to sit with somebody on this side if I want to hear them. This is super loud. And he's like, Melanie, you're smarter than that. I was like, well, I used to be 13% smarter, but he's like, what's going to happen if you directly dump arterial blood into a vein over and over again? And you've got like 40 or 50 more years to live. It's too high pressure for the vein, right? He's going to you're going to bust, you're going to cause an aneurysm in that vein. So what they did was, I didn't even notice. Maybe I'm supposed to be way smarter, but I wouldn't know, right? Because this is all the smart I am to notice. They shoved $30,000 worth of platinum coils up here. And, woo, insurance! Thank you for your support. This is coming from you. $30,000 worth of platinum coils up there, and they just shut down the blood flow. The other alternative was to open it back up again, but they were afraid I would throw a clot to my brain if they did that. So they just shut it down. So collateral circulation apparently works, right? And I got to see him do everything but the very last minute, and then he videotaped it for me. Go ahead, Chase.
Did they just go up another vessel to get there?
They went up my femoral artery, all the way up.
Wow.
All the way up, backwards.
Super cool.
I know, it was really cool. It was crazy. He let me watch the whole thing. He let me watch the whole diagnostic procedure, and he let me watch the whole thing until he got the coils right about in my neck region. And then he's like, you have to go to sleep. I'm like, all right, damn it. That's fine. Thank you, anastomosis. Okay, so let's talk about the kinds of arteries that exist. There's 3 different categories of arteries. And the 3 different categories of arteries change as you move away from the heart. The general trend is that elasticity is most important close to the heart, meaning that they're not very wiggly, right? And then you get way wiggly as you move down here, right? So elasticity becomes less important as you get further away from the heart, but muscular contraction becomes more important, okay? So the arteries that are closest to the heart, think aorta. That's a phenomenal example. It's called an elastic artery. Not because it doesn't have muscle, but because elasticity is its primary thing. And you don't use the muscle for constriction very often, okay? So the aorta is a classic example of an elastic artery. Once you get a little further away, you don't have to memorize which one's which, but definitely by the time you're in the brachial artery, for instance. You are now in the arteries in which you still got a lot of elasticity, but collectively there's like a lot of muscle in that compared to the size of the vessel. So this is called a muscular artery, not because it has more muscle, but just proportionally more muscle. And also the muscle is now more active in vasoconstriction and vasodilation. And then elasticity is not super important in arterial, comparatively speaking, but arterials are the wiggliest vessels that you have because they are controlling blood flow to capillary beds. And blood flow to capillary beds is differential depending on your activity patterns, right? So right now, no tiger in the room, I can be sending blood supply through arterioles to the capillary beds of my digestive tract and my uterus, right? Okay? And so those arterioles are wide open. And then a tiger walks in, and you do not want the blood going through those places. So what happens is the arteriole constricts there, but the arterioles, for instance, supplying my skeletal muscle, my heart, my brains, and my lungs, those will dilate. So arterioles are really wiggly, and they're really differentially wiggly depending on what you're doing with your body. They control blood flow through capillary beds. In addition, arterioles are also the gatekeepers and the protectors of the capillary beds. So let's just talk about this conceptually speaking. Capillary beds can't protect themselves against high pressure because they don't have any muscle in the wall and they don't have any connective tissue in the wall. And so what do you think that the arterioles would do to protect a capillary bed if systemic pressure was so high that it could damage them? Yeah, they constrict, yes, to protect it. Even if it adds to the problem of high pressure globally, they got one set of homies. And they're like, I won't protect you. Screw the rest of those folks. I didn't even like them anyway. So that's what arterioles do, and they protect the capillary beds. So we've got elastic, muscular, and arterioles. These don't have names individually. They are 0.3 of a millimeter wide, so they're hardly visible with the naked eye, and they're too variable. These you're going to learn in lab this week, and well, you're going to learn from me this week and in lab next week. And then these primarily are just the ones that are closest to the hearts, like the aorta and the pulmonary trunk. Okay, go ahead.
So when arteries constrict, does it increase the pressure?
Yes.
So it doesn't like stop blood from going to that area?
Arteries?
Yeah.
If an artery constricts, it's going to increase the pressure, which tends to increase flow. If an arterial constricts, it can stop blood flow through a capillary bed, because these are the ones that are right before capillary beds. Okay, so that's actually a good question, and it's probably makes a lot of sense that it's kind of counterintuitive to you, because there's really a couple of different reasons that you could constrict. If your pressure was too low, just talking, this is a little fizz, you don't have to understand it now if you don't want to. If my pressure was too low to deliver adequate blood flow to capillary beds, I would do like collective artery constriction, right, to bump up the pressure, right? But another reason that I could do artery constriction is to change blood flow patterns. But that would be regional and not global. Does that make sense? So that's a phys question, and it's a good one. It takes a little while for phys students to get it too. So if I didn't answer it adequately, you're welcome to ask again. But we do talk about it for like 45 minutes in phys. Go ahead.
So when you say they're more squishy, wiggly, are you just
They're more active in vasoconstriction and vasodilation, arterials, because they're controlling differential blood flow patterns.
Okay.
That make sense? Okay. All right. So, muscular or distributing arteries, we got those. Now we got arterioles, and those are the smallest ones. Luckily, those are the ones that you do not have to know by name. Those are the ones that are really massively controlled by sympathetic nervous system stimulation. And then when we get to capillaries, of course, capillaries are going to be the thinnest ones, the thinnest vessels that we have. So you always go, well, almost always, go from the ventricle to elastic muscular arteriole, right? Then capillary bed. And this capillary, this would be the arterial end, and this would be the venous end of the capillary bed. Which end is going to be higher pressure? Arterial end of the capillary is going to be higher pressure. You are going to massively slow down blood flow and drop pressure as you go through this. And this is kind of an important thing to start talking about so that you'll understand it when you get to phys. Okay, so let's say I have a bolus of blood that I just squirted into the aorta, usually around a 1/4 cup per squirt. Okay, and then that blood that is in the aorta now gets split into, I don't know how many, let's say 200 or 250 muscular arteries. Okay, what's going to happen to the pressure as you split it from one vessel to 250? It's going to drop. And what's going to happen to the speed of flow as the pressure drops? It's going to slow down, right? Now I'm going to split it from 250 to 10,000. To really slow down the blood flow and drop the pressure. And now I'm going to split it from 10,000 to millions, right? The good part about that is that as you go through a capillary bed and you're relatively low pressure, you've got more opportunity for gas exchange because you're going slower, right? Gas and nutrient exchange, right? Okay. So now we see part of the reason the pressure is dropping because into more tubes. Of course, we're also getting further away from the pump, right? And now the pressure is going to drop as you go through the capillary beds because you're going to go through millions of vessels, right? In addition, most capillary beds are porous. And even if they weren't porous, you're going to lose fluid via osmosis. So you lose fluid as you go through a capillary bed via osmosis. You'll pick up about 90% of it. You lose it via filtration. You pick it back up by osmosis, okay? So you push it out via filtration. You pick it back up by osmosis, but you always lose about 10% of it. So for those 3 reasons collectively, the blood on this side of the capillary bed is going to be way lower pressure than the blood on that side. So you've got further from the pump. You dropped it as you went through. You lost fluid, you've got way more vessels, right? So it's going to be way lower pressure as you get on the other side. So capillary beds lose a lot of fluid. So capillaries are, of course, the only place that you do any appreciable amount of gas exchange. So they have to be within millimeters of pretty much every cell in the body. So the only places in your body where you really don't have capillary flow are like the epidermis. But that's okay because it's thin enough that you get good nutrient exchange from the bottom. You don't have any in the cornea, the lens of your eye, or hyaline cartilage. That's not problematic unless you damage one of those things. If you damage one of those things, you're kind of screwed, right? You also have very few capillaries and ligaments and tendons, so they're not very good at healing either. Everywhere else, you have boatloads. And there's a direct correlation between the activity level of a tissue and the number of capillaries you have in the tissue. So the brain, of course, can have boatloads, and so is the heart. Does that make sense? Okay, so moving from capillaries, let's tell you one more weird thing about capillaries, and that is there is a really fast way of getting blood through a capillary bed. So I want you to imagine, shit, where did it go? Gotta find it. There it is. Okay, so they stripped the outside of this arteriole just so you could see the smooth muscle in it, right? It doesn't generally look like that. And then this is a venule as well. So I want you to imagine that this is a capillary bed in the wall of a uterus, right? And so the person is chilled out. So the blood is percolating through the capillary bed in the wall of the uterus, and then a tiger walks into the room. You need that blood elsewhere, don't you? So what you can do is, even though I told you that capillaries don't have any smooth muscle in their wall, they have little cuffs of smooth muscle that I could, in a pinch, close this one down and this one down and this one down. and make blood go really fast through the thoroughfare channel so that I could get it back into circulation. Those are called precapillary sphincters, okay? And they're usually only at the arterial end of the capillary bed, because you don't need them at the venous end if you got it going through the right direction from the arterial end. Does that make sense? So that allows you to shunt blood directly back into circulation more quickly. Okay, so there are 3 different categories of capillaries. Let's do those really quickly. Depending on how much control and transport you want. Okay, so as you move from this one, which is called a continuous capillary, to the other one, which is called a sinusoid capillary. So this one has tight junctions between the cells. It has a lot of control of what goes in and out of the capillary to the tissue around it, right? This one is the other extreme. No tight junctions, big holes, incomplete basement membrane, almost anything can get in and out. So this one has tight control, this one has very little control. This one is good at transport, but it controls it very carefully. This one doesn't control, and it's way better at transport. And that one's intermediate between the two of them. Okay, so let me give you an example of the places that you would find each of these capillaries. The one on the far side is called a continuous capillary, and continuous capillaries exert a lot of control over what gets in and out of the capillary and the tissue around it. And we have a phenomenal example of a place that you would have continuous capillaries. Anybody know? Blood-brain barrier of the brain. As a matter of fact, it's tighter than most continuous capillaries. It's called a continuous complete capillary. Tight junctions between everything. Nothing gets out of the bloodstream into the tissue without permission. I mean, except lipid-soluble stuff, you can't control them, okay? So that's like the blood-brain barrier. In addition, by the way, superficial capillaries very close to surfaces tend to be continuous because they don't want to take in things willy-nilly, so they have a little bit more control, the ones close to the surface. Fenestrated capillaries are designed for more transport, but they still don't lose complete control of the transport. So what it looks like when you look at a fenestrated capillary, fenestra means window, by the way. A fenestrated capillary, what it looks like is that it has a hole, but it doesn't really have a hole, it has a double-paned window. So we took one of those simple squamous cells and looked at it from the side. You would say, okay, I got that, I got that, I got that. Okay, so what you do in a fenestrated capillary is in some places you squish everything out except for 2 layers of cell membrane, so there's no organelles in there in the way, there's very little cytoplasm. So basically I have a little window. And since that is thinner, right, it's less of a barrier to transport. That's called a fenestration. Where do you find those? You find those in places where you want a lot of transport, but you don't want to lose complete control over it. Like for instance, the blood vessels that are immediately deep to the small intestine want to do a lot of absorption, right? They still want to have some degree of control over the absorption. Or the blood vessels in the kidney, those fenestra and the kidneys are less about what gets into the body and more about what gets out, right? So those are fenestrated capillaries. And then the last type of capillary is the one that is super wide, comparatively speaking, still microscopic. So same amount of blood here and here. Which one's going to be slower? That one's slower. Yeah, same amount of blood. If you have the same volume, and then you make the tube wider, right? It slows it down, right? Okay, so this one's going to slow down. They're also more windy. They're more curvy than other capillaries, okay? That will slow it down as well. And notice that these, which are called sinusoid capillaries, have incomplete basement membranes. They have hardly any tight junctions to speak of. Things can move in and out willy-nilly. Where do you want to use these? One of the places you use them is the liver. Okay, so you may or may not know this yet, but all of the blood that's absorbed from your digestive tract gets shunted through the liver before it goes back into circulation, which is really good because the food that you eat is not sterile. So let's say you ate some spinach that had E. coli on it, because it happens, right? Not all of you are going to get sick. Part of the reason you're not going to get sick is that blood, assuming that you absorb the E. coli, is going to go through the liver. And what the liver is going to do is all of the capillaries of the liver are sinusoid capillaries, and they're really curvy, so the blood kind of slowly goes through the liver. Sitting on top of those sinusoid capillaries are big liver macrophages, right? And they're looking down at the blood that's going by. When they see something funky, they grab it, and they do phagocytosis. and they whoop up on it. And they can do that because there's freaking holes, right? That's part of what's going on with your liver. It's like monitoring the blood that goes by. Okay, so let me give you another place that you will find these, and you tell me what's going on there. Another place that you find sinusoid capillaries is in red bone marrow. Can you tell me what the sinusoid capillary, how the sinusoid capillary will help in red bone marrow? Doing.
We can let red blood cells in the house.
Yes.
Well,
Into the bloodstream, right? So this time it's less about what you're pulling out of the bloodstream and more about what you're putting into the bloodstream. So you got these big sinusoid capillaries that are not providing a barrier when you made new blood cells and you need to put them in. That makes sense? Okay, so those are sinusoid capillaries. All right, so last type of vessel to talk about is the venules and veins. And a venule, by the way, is just a really small vein. And these guys are never named either. They're about the size of an arterial, sometimes a little bit bigger, a little smaller. They don't have individual names. They're just a small vein. And then we moved up to these smaller, medium-sized veins. That would be like the brachial or the radial vein or whatever. And then we have these big veins like the superior and inferior vena cava, right? Okay, so what's true about veins, we already know they're thinner walled and all that business. They're going to be way lower pressure. So one more time, I want to go through the reasons that a vein is lower pressure. First, way far away from the pump. Second, you lost pressure as you went through the system, yeah? Because you split it and split it and split it. You lost volume as you went through a capillary bed, right? And then there's another one. Veins are larger lumen. That's going to drop the pressure, right? And then there are about 3 times as many veins as there are arteries. And that drops the pressure as well, right? So if you're dealing with that same bolus that we started in the aorta, and now we've got it in all the veins working backwards, it's way lower pressure there. And low pressure becomes problematic when you want unidirectional flow of blood and it's working against gravity, right? So we have to deal with some stuff that will help with pressure in veins. So let's talk about that stuff. So many veins, not all of them, but especially the ones in your extremities, will have valves in them. And the valves do the same thing in veins that they do in the heart. They're to promote unidirectional flow of blood. I want it to go one direction, okay? So what do you think? Where are the veins in your body that has the most predisposition to backflow? Legs, exactly. Because they're far away from the heart, right? And they're going against gravity, okay? So those definitely have valves in them. And the valves, basically, if you get the blood up here, the valve is like kind of like a semilunar valve in its anatomy. So as the blood tries to go backwards, it gets caught in the cusp, and it can't go backwards. So what happens in this situation is the blood moves up. But what helps that is what we call the skeletal muscle pump. And the skeletal muscle pump means that if you have skeletal muscles near a vein, and you squish on them, the skeletal muscles will make the blood squirt, but it only can squirt one direction, right? So you increase the pressure here. Can't go back very far because there's a valve there, so it has to continue going up there. So what happens is, especially when you're active, what happens is the blood moves from here, and then you contract, and then it moves to here, so it's going kind of like going up a roller coaster, right? Moving up. So this, of course, works better when you're active. You get better, what we call venous return to the heart when you are active, okay? So what if the valve is weak around here? What if I have some weak connective tissue around the wall? What happens? You get varicosities or varicose veins. So varicose veins, here's some nasty ones. So these are nasty. You're more likely to have varicosities superficial because there's not very much skeletal muscle around them, right? And you've got a lot of superficial veins. You have hardly any superficial arteries if you've got normal anatomy, because that's not a good plan. But you have lots of superficial veins. So you can see these varicosities. And varicose veins are when you have ballooning out. Anybody know what predisposes some people, not other people, to varicosities? What?
Standing a lot.
Standing a lot is a big one. I hate to tell you, but nursing is one of the professions that predisposes you to varicose veins.
I think it's genetic too.
There is a genetic predisposition to it. It's genetics and environment, like almost everything else. But
I have one on my left.
you have one on your leg. You're so young and so active.
Yeah, but I stand a lot.
Oh.
Doing like manual labor or like standing jobs.
Walking is great. Standing is bad.
So do those stockings help with
The compression stocking, they help with superficial
like elevating
varicosities.
feet. So you
Elevated
gotta like be
feet.
like motivated.
Wiggling
to
is
do
the
that.
best thing that you can do.
It's so
Go ahead.
hard to do this socks
My
on.
mom had
Yes, you can have them removed.
Looks pain.
It's really painful though, isn't it?
Yeah, she said she's had her, she can't take like general anesthesia very well. So like she had a gallbladder on some other surgeries, and she said that the varicose veins are far the most painful.
I've heard it's
You
nasty.
can do
They strip
laser
them
now,
out.
right?
They can do laser for the small ones. When they're big like these, they can't do it for the big ones. So you can definitely do lasers for these little bitty varicosities. Like a lot of times they call these spider veins. By the way, why can you lose some of these and not care? It's because you have so much redundancy in blood flow with veins especially. And you have more variation in blood flow with veins and more superficial veins. There's 3 times as many. And sort of the way that I think about this is the whole, like evolutionarily, if blood is on its way to a capillary bed, there's tremendous evolutionary and selective pressure to not fart around, right? So you don't see somebody developing like 17 different turns on the way to a capillary bed and still having the same likelihood of survival and reproduction, just historically speaking, right? Okay. But then if you're on your way back home, right, it doesn't really matter how fast you get back there. It doesn't matter, especially if you're not active at that moment. As a matter of fact, at any given moment, 65% of your blood, if you are at rest, just farting around in your veins, just like making its way slowly back to your vein, to your heart, right? When you start becoming active, you shunt it all back. So there, it's annoying to anatomy students, but you are going to see tremendous amounts of variation in the venous system, way more than you will see in the arterial system, in any cadaver, any person. So the picture that you're seeing for the venous system in the textbook is just like how it is in maybe 40% of people, right? That's the best you can get. So you just look at it and like expect venous variation. So the reason that you can lose these is because you got a bunch of extra ones, right? You can just yank it out and you're generally going to be fine. There's all different routes of circulation back via the veins. Go ahead.
So what happens if you leave them in?
If you leave them in, they actually are kind of painful and they tend to get worse over time because you get less active over time and a lot of times your pressure increases over time. So you don't have to take them out. A lot of times people take them out because it's cosmetic, right? Cosmetic and also the pain, but it's not a comfortable surgery from what I've heard about. These, they just burn them off with a laser.
Oh, I can't
Yeah.
feel it. It's on this side.
So the things that predispose you are your genetics, so just weak connective tissue in the wall, maybe a little less musculature, and your sort of lifestyle. If you are more active, you are less likely to get them. It also, pregnancy predisposes you to those because it increases the pressure so much up here during pregnancy. Does that make sense? And blood flows from high pressure to low pressure, right? So if the pressure is way lower here, it's going to be really hard on the valves during pregnancy. So varicosities are even harder to deal with when they occur in the anal canal. And a varicosity in the anal canal causes a hemorrhoid. And hemorrhoids are when you get the ballooning out of the blood vessel in the anal canal. Those are typically associated with what? Bearing down, sitting a lot, being a truck driver, being relatively inactive and a truck driver, and pregnancy. A lot of women didn't know a damn thing about hemorrhoids until they got pregnant. And now they wish they didn't know a damn thing about hemorrhoids. Because they don't really go away, just so you know. They like stay there, and sometimes you have to have surgery to have them repaired. Sometimes you just have to deal with them.
Are hemorrhoids and fissures the same thing?
No, well, fissures are when you have a tear.
Okay.
A lot of times they do come together. Like you can get both of them simultaneously. Yeah, but you don't have to have fissures. So my missionary work is to make sure that nobody has a baby if they don't want one, right? So, right? Is it working?
Yeah.
Okay, good. Being a parent is hard. Being a good parent is really hard. Okay, so that's hemorrhoids. Okay, so what do you call the biggest vein, biggest normal vein? I'm not talking about a hemorrhoid. You call the biggest normal vein a sinus. So sinuses we will run into. You have already run into some sinuses. Remember, you learned the superior sagittal sinus and the transverse sinus and the coronary sinus. You are more likely to find a sinus being a vein than an artery because veins have a bigger lumen. Now you do have a couple of arterial sinuses, like the carotid sinus, which is like the split between the internal and the external carotid, but you're going to see far more venous sinuses because you can have a bigger lumen, and it's not much of a problem having a bigger lumen. So that's what a sinus is when you talk about them. Okay, so now let's just start with circulatory roots. Okay, so the way that you guys are going to do lab next week, and the way that a lot of times people do lab, has a strength and a weakness. Generally, because lab gets kind of overwhelming, all you do is point to a vessel and you name it. But in lecture, that won't serve you, because what I need to know is I need to know which direction blood is flowing through that vessel, right? So when you start talking about circuits, you always want to talk about what an artery is supplying, because that's what it's doing, right? And what a vein is draining, right? Does that make sense? So instead of, for instance, talking about this as, okay, this is the radial artery. Sure, that's the radial artery. I will ask you what the radial artery is supplying. And it's not that hard, because the radial artery is generally going to supply the lateral half of the arm, right? What are other things supplying? What is the splenic artery supplying? Because if I do that to you, it forces you to think about blood flow instead of just naming vessels. And then, even more important, and people have a harder time with this one, veins, you don't trace them from the heart, you trace them back to the heart, right? So if this is the radial vein, what is the radial vein draining, and where is it draining into, right? So you follow the radial vein. Ultimately, you are going to follow all systemic veins back to the superior and inferior vena cava, the coronary sinus, right? And then back into the heart. Does that make sense? So what I want to do is I want to get you guys into the habit of thinking about blood flow, not just naming vessels, okay? So we'll start with the easy one first. We're going to do pulmonary circulation first. Pulmonary circulation is going to, the pulmonary circuit goes from which heart chamber? Where does it start? Right ventricle, exactly. So we're going to go right ventricle. We'll do the basic parts in just a second, and then we're going to go through the pulmonary capillary beds, and then we're going to go back to the heart into the left atrium, right? So pulmonary circulation, before we get into the actual vessels, I'm going to tell you something about pulmonary circulation. So when you do systemic circulation, the blood pressure number that you probably have in your head as normal is 120/80. So let me tell you what that is so we can compare it to pulmonary circulation. 120/80 is 120 millimeters of mercury versus 80 millimeters of mercury. What that is of course systolic and diastolic, but what does that have to do with anything? What it has to do with is 120 millimeters of mercury is the pressure in your, for instance, brachial artery immediately after ventricular contraction. So that's the high end, right? Okay. And what's the 80? The 80 is immediately before the next ventricular contraction, so that's the low end. So do you see what that one does? So 120/80 is the typical at-rest pressure, right, for the brachial artery in systemic circulation. Now let's compare that to pulmonary circulation. Pulmonary circulation is 25/10, okay? That means immediately after right ventricular contraction, the pressure in the pulmonary arteries goes up to 25 millimeters of mercury. Immediately before the next one, it's back down to 10 millimeters of mercury. So I have two different but related questions to ask you about that. The first question is, why is that pressure adequate for pulmonary circulation? Why does it get the job done?
Goes far.
It doesn't have to go very far, right? Okay, you're just going heart, lungs, right? Okay. And the next question is, what anatomical difference is responsible for the pressure difference? What is it that is responsible for the pressure difference in systemic and pulmonary circulation? You guys know this. Yeah, it's the heart wall, exactly. It's the heart wall. It's the thickness of the left ventricle versus the right ventricle, right? Way more musculature generates way more pressure. Way less musculature generates way less pressure. Now, conceptually, what is going to be harder on a system of tubes? Chronic higher pressure or chronic lower pressure? Higher pressure. Do you see now why systemic circulation problems are far more frequent? Not only do you have more tubes to go wrong, but you've also got higher pressure constantly in all the tubes. So systemic circulation problems are very, very common compared to pulmonary circulation problems. Is that okay? Okay, so when you're dealing with pulmonary circulation, it ain't that hard. First of all, your textbook doesn't even have pictures of most of it. But let's talk about the ones that you are going to have to learn. So you're going to start at the right ventricle, right? And they're going to leave through this valve. And what's that valve? Pulmonary semilunar. By the way, sometimes they just call it the pulmonary valve. So if you ever see somebody refer to a pulmonary valve or an aortic valve, it's pulmonary semilunar, aortic semilunar. So you're going to leave here, and then what vessel am I in right there? Pulmonary trunk. And then the pulmonary trunk is going to split into the left pulmonary artery and the right pulmonary artery. They're not showing it here, but I'm going to tell you the next split because it makes sense. The next split is the right pulmonary artery will split into the 3 right lobar arteries, because you got 3 right lung lobes, okay? And then the left pulmonary artery will split into the 2 left lobar arteries. Good? Okay? And of course, those are going to split. Smaller arteries, arterials. And then ultimately, let's look at the weird capillary beds that you have in the lungs. The weird capillary beds that you have in the lungs are the reasons that the lungs can do their job so effectively. Okay. So ultimately, what I'm going to have in the lungs is the lungs are like a really, really dense sponge. So like one of those expensive sponges that you get from Williams-Sonoma or something at a kitchen store. They're really super dense. So what they are is tons and tons, millions of microscopic little bubbles that are ultimately connected to the bronchi and the bronchioles, and they split and split and split and split, and then you have these teeny tiny bubbles. These teeny tiny bubbles are called alveoli, collectively. Individually is an alveolus, okay? And inside each teeny tiny bubble, you are going to have air. So the wall of the alveolus is made of simple squamous epithelium with just a stretchy basement membrane underneath it. You guys with it? Okay, so now what I'm going to do is I'm going to take a very, very thin, highly branched capillary and run it by very, very thin air sacs, right? So this is ultimately a branch that I could follow back to the pulmonary arteries. Yes? So what I'm going to do is I'm going to follow this one, okay? As I follow this one, I'm going to deliver this low oxygen blood, because that's what you have in the pulmonary circuit, on this side anyway. I'm going to deliver it and run it right by this air sac. And the air sac is thin, and it's branched, and oxygen is lipid soluble anyway. So oxygen moves into the bloodstream, carbon dioxide moves back into the alveolus, and then ultimately I get blood oxygenated as I go through this. I do this on every single alveolus. You have surface area for gas exchange in your lungs the size of a tennis court. That's how much surface area you have for gas exchange in your lungs. It's phenomenal surface area. So you get all of this gas exchange going on, right? And then ultimately the blood that is now oxygenated goes, this is headed back for the pulmonary veins, right? Headed back for the pulmonary veins and ultimately back into the left atrium. That makes sense? So that is pulmonary circulation. Let's just briefly talk about one disorder associated with this. One disorder associated with this is emphysema. One of the things that happens with emphysema is you take those little grapes, right? So you got this little cluster of grapes, like an alveolus cluster right here. And with chronic emphysema that you can get from smoking or exposure to respiratory irritants, like working in a coal mine and stuff like that, you take that, and over time, it breaks down from a grape cluster to a grapefruit. And what happens to your surface area for gas exchange when that occurs? Yeah, you dramatically less. You are having trouble getting adequate gas exchange into your bloodstream. So you're low oxygen in your bloodstream, which means your heart has to work harder and your respiratory system has to work harder. Does that make sense? That's what chronic emphysema can do to you. Okay, so that's pulmonary circulation. Of course, systemic circulation is way the hell more complicated because there's a lot more vessels in it. There's a lot more to learn. So let's just start on systemic circulation and talk about it. So the way that, there's a million ways that you could approach this. I'll tell you my approach, so at least you'll know what my plan is, okay? So systemic circulation, when you're doing systemic circulation, of course, you're going from what heart chamber? Left ventricle, right? And then you are going to go through the aortic semilunar valve into the aorta, right? And so what I'm going to do, since all blood flow to systemic circulation comes from the aorta, what I am going to do is I am going to deliver blood off of the aorta to the organ and then back to the heart before I deliver it to another place, okay? So does anybody know the only 2 branches off of the first part of the aorta? The first part of the aorta is called the ascending aorta. What are the only 2 branches off of there? Right and left coronary artery. And you already learned that one, right? Okay, so what I want you to do as we are talking about blood flow is to think about what it's serving. So the ascending aorta has two branches that deliver blood or serve or supply the heart muscle itself, right? And then we'll deliver it back to the heart through the coronary sinus. We don't have to go through that one again because we've already done it, okay? But then what I'm going to do is I'm going to deliver blood off of the aortic arch because that's the next part I come to. Not surprisingly, the aortic arch will pretty much deliver blood to the head and the arms, right? And then I'm going to deliver blood off of the descending aorta, which will deliver blood to the rest of the thorax and then all the way down, okay? And so each time what I'm going to do is deliver arterial blood and then deliver venous blood back. Does that make sense? Okay, so arterial blood, 2. So systemic circulation with arteries, you follow them all back to the aorta with systemic circulation. It all goes back to the aorta. With systemic venous circulation, it is all going to end up one of 3 places. With systemic venous circulation, it's going to either end up in the inferior vena cava if it came from below the heart, right? The superior vena cava if it came from above the heart. And what vessel if it came from the heart? Coronary sinus, right? So we're going to follow it back. And so what I'm going to do here is to try to get you guys thinking about blood traces, right? Luckily, all systemic blood traces are pretty damn easy because they start in the aorta and they end up in one of those 3 vessels. Superior vena cava, inferior vena cava, or coronary sinus, right? Okay. All right. So the problem with veins is this, okay? And this is what students hate. It's not that hard, though, because it's not like as hard as muscles. So I want you to look at how many blood vessels, how many arteries you have in the arm, okay? And then compare that to how many veins you have in the arm. Do you see? Yeah. The venous pattern is way more variable, and it's way, there are a lot more veins. There are 3 times as many veins as arteries. You don't have to learn 3 times as many. You don't learn a whole bunch of the superficial veins, but expect variation when you look at the venous system. And don't get too thrown by it. It's just like an anomaly. Like, doesn't matter most of the time in veins. Okay. So, let's start with systemic regional blood flow. Okay, so the way that we're going to do this is we're going to follow everything from the aorta. So let's start at the aorta. One more time. This part of the aorta is ascending because that's the direction that the blood is going. This is the aortic arch, and this is the descending aorta. So first branches, only branches off of the ascending aorta are the right and left coronary artery that deliver blood to the heart. And then the blood's going to come back ultimately to the coronary sinus, right? And then the right atrium. So I'm not going to tell you that one again, but I'm going to tell you that you're responsible for that one twice because it's both part of the heart and it's also part of systemic circulation. Okay? Good? Okay, and then we'll go to the next one. And so next thing that I give blood to, starting from this picture, will be the 3 branches off of the aortic arch. Okay? You've got 3 branches off the aortic arch, and they're not very hard. Okay, so let's look at them. The 3 branches off of the aortic arch. This first one is called the brachiocephalic, which is trying to tell you something. It's delivering blood to the right arm and the right side of the head. Yes? This one right here is called the left common carotid. Now, carotid doesn't say head, but you know where the carotid canal is, right? So that's going to tell you that's going to the head. And then this one is called the left subclavian because it goes under the clavicle to the arm. Okay? So let's just look at this variation in pattern really quickly because there's a reason that it exists. So in 90% of us, maybe even more, the aorta curves left. So it goes over to the left side of the body. There's a few people that have it curved to the right. When it goes over to the left side of the body, that means you can get direct blood supply from the aorta to the left side of the body. But to the right side of the body, you have to jog over to get there. Do you see that? Mm-hmm. So with this one, what you're going to have to do is, so just follow me for a second and you'll learn the names of the vessels in just a minute. The aorta is branching left. You get over to the right side, you go brachiocephalic, and then you split into right common carotid and right subclavian. Because you have to get over there, right? But if you're going to the left side, do you need to jog over there? No. The left side just does left common carotid and left subclavian directly off of the aortic arch. Does that make sense? That's why it's like that. Okay. We do have one cadaver on Redwood Campus that has 4 branches off his aortic arch. He's the same one that has the pacemaker and like 2 or 3 bypasses. He's just got kind of a weird cardiovascular system. He's also got 2 renal arteries on one side. He's got another one like tucked back there. It's confusing as hell to figure it out, but I'm fairly certain that that extra artery on the back is the vertebral artery, which goes up the backside. It usually branches off way out here, but his branches off right there. The only reason I don't know yet is because I'll have to destroy the left side of his neck to confirm what it is, but I'm pretty sure it's the vertebral. So don't let it confuse you, it's fine. Okay, so let's do brachiocephalic. So what the brachiocephalic does is delivers blood over to the right side, specifically to the right side of the head and the right arm, right? And it's going to split into the right common carotid and the right subclavian artery. Does that make sense? Okay. Now, common carotids, once you get there on both sides, they do the same thing. Same thing with subclavian. Once you get there, they're parallel to one another. So, so the right subclavian supplies the right shoulder and arm. The left ones do the same thing on the left side. They're just branched slightly differently. So let's look at them, and let's just deliver blood supply to the head. Okay. So first dibs on blood supply, can you see, is going to be the head? Do you see? Right after, well, the heart's first, and then the brain, right? And then the head. Okay, so what I'm going to do is I'm going to follow the common carotid. But one more time, if I want to get to the right side of the brain, get me there from the aorta. Aortic arch, then brachiocephalic, then right common carotid. By the way, if you haven't learned this yet, if you have a common vessel, it means it's about to split. So if you have a common, it's going to split into an internal and external, or a superficial and deep, or something like that. It's going to split into something. So the common carotid is called common and before it splits. So let's follow blood supply to the brain. If you were going from the left side, you just go straight from the aortic arch, right? Left side straight from the aortic arch to the common carotid. So let's follow that up. Okay, so let's flip the picture. We're on the right side. Here's the brachiocephalic artery. I know I'm being redundant, but I'm going to ask you again. Where was the blood right before this? Aortic arch, exactly. Okay, so we're on the right side. We've got the brachiocephalic artery, and it's going to split, and it's going to give rise to the common carotid. Okay, this is the carotid sinus, by the way. That carotid sinus, if you press on it, you can really, really feel your blood flow to there. Be careful, because if you compress it too much, especially if you compress both sides, you're going to effectively compress the blood flow to your brain. Vast majority of your blood flow to your brain goes through this vessel right here, which is the internal carotid artery that goes through the carotid canal. Does that make sense? Okay, so 70 to 75% of the blood supply to your brain goes through this pair of internal carotid arteries. So why internal versus external? Well, it's basically telling you what it's supplying. The external carotid artery stays outside the skull and supplies the vast majority of blood supply to the skull and the facial muscles and the skin here. And then the internal carotid, the pair of them, supply the vast majority of the blood supply to the brain. Does that make sense? Okay. So, and note to self, do not label them at the branch point. Follow them. Because those little buggers do this before they straighten up, right? So follow them to see where they end up. Right, just like you did with like muscle tendons and stuff. Okay, so external carotid, internal carotid. There's a bunch of other blood vessels. You're not going to learn most of those. Now, this is delivering blood supply to the brain, but in addition, there's one other thing, and I'll just tell you now, and I'll reinforce it in just a second. There's another blood vessel right there, which is this guy right here. That is the vertebral artery, and the vertebral artery, the pair of them, delivers the other 25% of blood supply to the brain. And they go up the transverse foramina of the cervical vertebra, right? Does that make sense? Transverse foramina of cervical vertebra. And those are going to deliver blood supply to the brain. Okay, so let's look at that in a little bit more detail. Okay, so the left and right common carotids, most of the blood supply to the brain, internal, external carotids. And then let's look at the rest of the blood supply. Okay, so now we're ready to talk about subclavian, but the first thing I want to do when I talk about subclavian is to finish off blood supply to the brain. Okay, so if I was doing the subclavian, That's going to end up delivering mostly blood to the shoulder and the arm, but there's one little branch that goes up to the brain, right, which is the vertebrals. So the first branch off of the subclavian that you care about, it's not really the first branch, is going to be the vertebrals. So let's look at these. Okay, so what is this related to the brain stuff that you learned before? Okay, these two right here are the cut internal carotid arteries that came up through the carotid canal, okay? They're going to come in right there by the octic chiasm and the pituitary gland and deliver blood up to the brain. Good? Okay? And these guys and these guys. So these guys came up the lateral sides of the cervical vertebra, and then what they do is they fold anterior to the medulla oblongata. Yeah? They're folding anterior, because that's anterior, to the medulla oblongata, and they run up as vertebral arteries. And then they come together to form this one that runs right down the cleavage of the pons. Yeah? That one's called the basilar artery. Good? Okay. And then they form this circle, which is called the cerebral arterial circle, or the circle of Willis, which is like our body's most important example of collateral circulation. Is that okay? And in future semesters, you will probably have to learn the names of all of these little vessels, but I keep losing that argument with my colleagues, so they're not in there yet. Like, you can learn that one. Like this, like, anterior communicating artery, anterior cerebral, and this one's posterior. That's not that hard, right? Posterior cerebral artery. But I just really like this stuff, so. Okay, so this is most of the blood supply to the brain that you actually have there. Everybody okay with that? So you got your vertebrals, your internal carotids, and your basilar. Those are the ones that you guys are going to be responsible for. Collectively, the whole thing is called the circle of Willis, or the cerebral arterial circle. Okay, so last thing on the head is, how about we get blood back from the venous drainage of the head. So venous drainage of the head. So tell me, before we even go any further, where do you think that the blood that supplied the brain is going? What vessel do you think it's going to end up in? Jugular, and then superior vena cava, right? So if you think about it, you can predict it. It's less memorization and more prediction. Okay, so let's look at how that actually works. So in addition to all of the little blood vessels that you have in the head, you have, again, these are blood vessels that you already started to learn. Remember, they were called dural venous sinuses? And the dural venous sinuses have two jobs. They're draining venous blood from the brain, but they're also draining excess cerebrospinal fluid from the brain, okay? Collectively, you're learning some of these in lab, and I haven't put them all in there, but you definitely know the superior sagittal sinus, right? And I think you know the sigmoid sinus, don't you? You didn't learn that one? I'll put that one in there later, but not today. So there's transverse, but all of these, I want you to look at where they gather. All of these gather into the internal jugular vein, right? And that goes through what hole? The jugular foramen, right? That makes sense? So you deliver blood up to the brain through the carotid canal. It comes back from the brain through the jugular foramen, right? And so the internal jugular vein is now going to come back down. You don't have to know most of these. So let's put that back into context of the rest of the stuff. So now, gather everything from those dural venous, where did it go? From those dural venous sinuses. And now we're going to look at venous drainage. Okay. So the vast majority of the venous drainage from the brain goes into the internal jugular vein. Okay. You're going to drain a little bit more of it through the vertebral vein, right? Those are going to dump into here. Okay, so let's talk about what happens after you dump them into there, because that can be kind of confusing. Okay, so now I'm going to dump them back in. So let's orient ourselves right here. Okay, so coming from inside the head is the internal jugular vein. This one's going to be the external jugular vein, even though you haven't learned it yet. Once you gather up all the blood from, stick with me, the arm and the head, once you've gathered it all up, this is the brachiocephalic vein. Okay, because it's arm and head. You have, unlike only having one brachiocephalic artery or trunk, you've got two brachiocephalic veins, because I need to get all of that blood together into the superior vena cava. So let's do it again on this side. Internal, external jugular subclavian come together to form brachiocephalic. And then when the two brachiocephalics join, it becomes what? Yeah, that's how you make a superior vena cava. The two brachiocephalics joining together become the superior vena cava. that okay? Okay. Is this logical to you guys, or is it's pretty logical to me? But then I know it, so it's easier to make things logical after you already know them. Okay, so the internal jugular drains the brain, and it's really collecting blood from all of the dural venous sinuses, right? Superior sagittal sinus, straight sinus, sigmoid sinus, all of those. It will go through the jugular foramen to exit the cranial cavity. The vertebral vein drains the remainder of the brain into the subclavian vein, right? And then the external will drain the facial muscle in the scalp. So let's find the external here. So internal, follow it from inside the head, right? So can you find the external right there? By the way, this dumps wherever the hell it pleases. Sometimes it dumps here and sometimes it dumps there. This doesn't really matter, right? So when do you know you're in brachiocephalic? After you dumped all the head and all the arm together, then it's brachiocephalic. How do you know which one's which? You follow it from where it drained, right? And that's how you can tell it's external versus internal. So I've got internal carotid, external carotid, vertebral, dumping collectively into the subclavian, and then the subclavian becomes the brachiocephalic, and they come together to form the superior vena cava. Is that okay? Okay. Do you guys have questions? No? Everybody good? Okay. That's how we're going to do the whole rest of it. So the next thing that we're going to do is we're going to deliver blood to the arms and back, right? Where do you think the blood is going to go back from the arms? What vessel it's going to end up with? In what? Superior vena cava, exactly, right? Does that make sense? So it's going to end up. So what I'm trying to get you guys to know, to think about, is that a lot of this is logic, right? Once you learn how to predict the patterns, then you can just confirm the patterns, right? Instead of rote memorizing everything. That's why, to me, I don't think the cardiovascular system anatomy is very difficult at all. Most of the things are named what you expected them to be, right? You got the brachial artery in the arm, you got the radial on the lateral side, you got the ulnar on the other side, and then most of them end up back where you expect them to. There's just a couple of little anatomical variations, which are exceptions to your expectation, but other than that, it's pretty good. It's pretty fine. Okay, everybody cool? Okay. Go ahead.
Did you change the notes? Did you like add new things to them?
I think so.
Oh, okay.
Do you guys not have the newer ones?
So was that?
I will fix them for you and upload them, but I might need an email to remind me.
Okay.
I think I changed them and forgot to upload the newest version. They're not very much different. You don't have to reprint them anyway. There's just a couple of different things. Okay, yeah, go ahead.
Did you say this next test is the hardest one? Because it contains the brain and the.
It doesn't have the brain. The last one had the brain.
Oh, I got it.
Brains over here.
Just cranial nerves.
Yeah. The spinal.
Huh?
No, the peripheral.
Yeah, cranial nerves, the rest of the spinal cord and peripheral nervous system, which I don't think any of that's hard, honestly.
So last test was harder than this test.
I went easy on you guys on the last test, honestly. I was like, I didn't ask hardly any hard brain questions. You guys know I didn't. Okay.
You said the brain is the hardest, and so then when
I've been trying to like spread it out, because last semester what happened is like people are like, I'm smart, I'm smart, I'm smart. Oh my God, I'm never gonna pass this class. So instead I like kind of rearrange things, because I would rather you know, I'm not quite smart enough, I'm not quite smart enough, I'm not quite smart enough, I'm exactly what I expected, right? Other than taking, and last semester my last phys test, everybody tanked it. Well, not everybody, like 60% of the class tanked it. And I was like, well, I guess I have to move things around. And I did the same thing with anatomy. So I think it's like more evenly spaced. I don't think this is a hard test. But I don't really think I write hard tests, honestly. I think I write very reasonable tests.
You've just been talking about how hard the test is. And so I've been like,
I was for this test?
well,
They said what makes you study?
I'm just talking about the quiz, because you haven't been quizzed in a while, and you had spring break, and everybody's dumb now. Yeah, myself included. I'm like, well, there's a word, and I can't come up with the word, but it has some letters. I don't know what it is. So we're going to stop there, actually, because you guys are a little ahead of the other class. So we'll stop there for today.
I don't know. I feel like to prepare.
I don't think they're that bad. But I don't try to make them tricky, you know. It's just that with anatomy, there's literally what?
I think they're like reinforcing what we're learning. They're not like so easy that it's like none of us are prepared. I don't know.
Right.
I think it's like good math.
I try very hard to make them very reasonable. And also, it's less work for me if I make them reasonable, because I don't have to deal with people who argue and say, you didn't talk about this. I'm like, I literally did, it's right there, and also I've got a video.
Well, the point is like for us to learn and be able to apply our knowledge, like feel clear, like
That's the objective.
so it's like I don't know. It's nice to not constrict or like let me just like make these memorize things. Like, well, let's see if you actually understand the concepts. Basic
Yeah.
concepts.
With memorization too, because you need to do some of it. Yeah.
Do I have to make an appointment to come with you?
On Thursday?
Office hours?
No, I'll be there.
And I can just, if I have a question about like cardiovascular.
Yeah. I'll be there. I've got office hours on Thursday right after this class.
I don't